Good evening, everybody. My name is Ibrahim Sbeih, and we are transmitting live from Farah Medical Campus here in Amman. And the backdrop is Petra of Jordan, which is one of the 7 wonders of the world. Our topic for tonight is the Rathke cleft cyst, and we'll discuss the clinical, radiological, operative, and pathological correlation. So what is Rathke? There is something called Rathke's pouch, where there's a pouch that comes from the pharynx and goes into the forming a brain, and this will be met with another pouch coming from the brain. So there is a pouch coming from the pharynx and a pouch coming from the brain itself, from the diencephalon, and they will meet to form the pituitary gland. That occurs, this pouch occurs at the 4th week of gestation, and hamil, and the meeting appears in the 8th week. So one pouch from the pharynx, one pouch from the diencephalon, from the brain. This is going to form the anterior pituitary, and this is going to form the posterior pituitary. As you see, this canal, which is called the cranopharyngeal canal, will disappear, but there remains some cleft there inside this pouch. So the pituitary gland will be formed, anterior pituitary and posterior pituitary. So this pouch coming from the pharynx will form most of the, or all of the anterior pituitary, which we'll discuss the parts of it, and this will form the posterior pituitary or neurohypophysis. So that's the end of the story. The anterior pituitary, the posterior pituitary, and the pouch, which is here inside between the anterior and the posterior pituitary. The anterior pituitary is made of many parts. The main part, which is the lateral part, and then the intermediate part, and then there is something that's going around and cuddling the stalk. It's called pars tuberalis. So all these is made of the pharyngeal pouch. So the Rathke pouch, which is coming from the pharynx, will form the pars distalis, which is the anterior lobe, the pars intermedia, which is in the intermediate lobe, and the pars lateralis, which is cuddling the stalk itself. While the infundibular pouch coming from the diencephalon will form the posterior pituitary. So here you are. This is your pituitary. It's only 5 grams. It's actually less than, it is 1 to 2 grams, and it's made of this anterior lobe, and this is the posterior lobe, and the stalk going to the posterior lobe. So this is the lateral part of the anterior pituitary. This is the intermediate part, and around the stalk here is the pars tuberalis. So here you are, the lateral wings, the intermediate, the posterior pituitary, the stalk, and the pars tuberalis. So this is the pituitary in full, anterior and posterior, the stalk. Here we dislocated them so that the stalk will remain with the posterior pituitary. And this is the picture. This is the pars tuberalis. So if you take this and put it in the cella, that's what we get. This is dorsum celli, stalk going to the posterior pituitary, and the anterior pituitary is there. And this, of course, has so much relations with the optic apparatus. So at the end of the day, you have your pituitary like that, anterior pituitary, posterior pituitary, the stalk going to the posterior pituitary. So what is Rathke's cleft cyst? If that remnant remains, then it's going to cause a cyst. So that's the, remember, that's the cleft, and it should disappear. If any cells remain, it will cause a cyst. So the cyst will form in here. It is called cellular type, or it goes up, cellular, supracellular type, or completely above the diaphragm, and it's called supracellular type, according to the embryology which we have just discussed. As there is epithelium-lined pouch there, so it will secrete mucin, and it will form a cyst. This is a picture of the cyst. Is there any relation between the Rathke's cleft cyst and the clinical injury? Yes, because both will originate from this Rathke's pouch, and people believe that these two are kind of related to each other. So they belong to the same family of ectoderm. And there's a paper, it's a very lovely paper, persistent craniopharyngeal canal. You can actually see the canal coming from the pharynx going to the cellar. And in this case, the pituitary is all deformed, the stalk is elongated, etc., etc. Very nice paper. So who's Rathke? It's Martin Heinrich Rathke, he's a German anatomist, and he's considered to be the founder of modern embryology. He lived between 1793 and 1860. At the time, we in the Arab world were in full sleep. So he was the first to describe this pouch as embryology, and he was the first to describe an incidental post-mortem finding, 1859, just 1 year before he died. And that's the name of the paper. I don't speak German, but it's Über die Entstehung Archive. Thank you. So your information is very French. So, what are the contents of this system? It's mucin, of course, because the epithelium will secrete mucin, and it is mixed with cholesterol and protein. And you can get anything between a CSF-like, watery-like, to engine oil, to milky, or to the yellowish. And looking at the radiology, you can tell what is the content. Here it looks like CSF, so it's fluid content. In here, it's high proteinaceous material like that. So this is different pictures of different Rathke's cyst. You can see it's going to be milky, there is some mucin, etc., etc. What's the incidence? You would be surprised. It is the most common incidental discovered cellular lesion followed by pituitary adenoma. It's much more common or commoner than the pituitary adenoma. But not all these cases that we discover accidentally are symptomatic. Which age? Any age. 6 months to 90 years. Peak is 30 to 50. Females, luckily, are more than males. Lucky for us males. Location, what do they occur? As we said, they could be cellular, type 1, or cellular supracellular, type 2, or completely above the diaphragm, it's called supracellular, totally supracellular. And this is a very nice paper, supracellular Rathke's cleft cyst, clinical presentation in 2011 in Neurosurgery. Intracellular Rathke, as you can see. Cellular, supracellular Rathke. Again, cellular, supracellular. Cellular, supracellular. Cellular, supracellular, different types. And you can get it entirely supracellular. There's nothing in the cellular, it's all supracellular. And we know now why, because of the embryology that we just described. Extremely rare. Those that are totally, entirely supracellular are extremely rare. Only few cases are reported in literature, and our case is one of those. It's very, very rare. So this is entirely supracellular. So it could be, as you said, cellular, supracellular, or completely supracellular. Are there any other sites? Yes, it can go to the cavernous sinus. It can go to the frontal area, it can go to the cerebellopontine angle, it can go to the petroclival area. This is one case reported. The cyst is a pre-pontine. And this is one case of mine where the cyst is totally within the cavernous sinus. What's the natural history? As you said, it is very common on autopsy cases. So what is the natural history? It's not yet clear. We don't know what is the exact percentage will grow and what is the exact percentage will remain as it is. But the reported incidence in literature that 6 to 31% will progress. What is about involution? Do they just disappear? Some cases are described where they just disappear. Please.
As for the case which
invaded
the cavernous sinus, was that invasion or was what?
No, it was extended.
Extension.
Yeah, extension. The same thing with the pre-pontine.
Just inferior. Yeah, pre-pontine goes inferior. For the cavernous sinus, it went inferior, right?
Yes.
It is reported that sometimes it may invade the cavernous sinus and to present with cavernous sinus syndrome.
Absolutely, yes. In fact, that case was presenting as compression, but it was not actual sort of invasion. It expanded and went into the cavernous sinus, presenting it sometimes.
And it affected the nerve.
Yes, of course. Absolutely. So let's look at this natural history. And the best thing is to go and see how many of the kids that we diagnosed went on to develop some symptoms. This is a paper by Zada and his colleagues published in 2009. They reported 51 patients of pediatric population, 51 child in this period of time, and 10 patients only out of the 51 needed surgery. So this is one example. Another example by Jung from South Korea in Annals of Pediatrics, 2017 recent paper. They reported 91 children. The age was between 1 year and 17, and the size increased in 27%. So the range is really wide. What about radiology? How do they look like? On CT, you will see low density. Sometimes you may see calcification, but calcification is rare. MRI on T1, they could be hypo-intense, hyper-intense, hyper-intense, so you don't know. And they are equally distributed. That's the difficulty. So, what is the pituitary in all this? The cyst will enlarge, and it will take the cyst, the pituitary, either anterior superior, or inferior. So the position of the pituitary gland may be displaced in any direction, but usually around the cyst, sometimes under the cyst, and it is called IG in Latin.
Other question,
please.
Yeah, does it affect special hormone, or is there anything to, for example,
I'll come to it. So the displaced pituitary gland is here. It's here. It's here. And maybe this is the cause of some contrast enhancement. So when you see contrast enhancement, it's because you are seeing contrast enhanced pituitary gland being displaced. So the contrast enhancement sites, usually they are not enhancing, but an enhancing rim of displaced pituitary may be seen. And this you can use if you are going transnasally. You say, well, the gland is here, so I may go this way. So you go more posterior to avoid the pituitary gland. Here is totally posterior. Here inferior. Here is surrounded. So the contrast enhancement in Rathke's pouch, Rathke's cyst, is due to the pushed pituitary gland, or sometimes it's because of the cyst itself, because it has mucin, and this may cause inflammation. And some people say maybe it is metaplasia from the columnar epithelium into squamous epithelium. Look at this. The optic apparatus, and here is the contrast. So they could be large. T2, they are hyperintense in 70% of cases. This is from Osborne book. The others are my cases. So you can see the difficulty in diagnosing these cysts. Look at T1 and T2. T1 and T2 in this case. different from T1 and T2 in this case, from this case, from this case, and from this case. That's the difficulty of diagnosing Rathke. So T1, T2, and T1 with contrast. Flare would give you hyperintense. Size could be small, as we have seen, or it could be giant, 5 centimeters. One case reported in literature. And you may find a cyst with some nodule in it that is showing protein in it, or you may find some blood presenting like apoplexy. It may get infected. So there are cases of infected cyst. This case of Jahangiri, only 10 cases actually reported in literature. What are the symptoms? They can be asymptomatic, and the reason why I'm saying this is that 5 to 35% of autopsies show this Rathke cyst. So people are living with it, they did not notice it. On autopsy, you find that they have Rathke. So it could be asymptomatic, or it could have symptoms, and that's your answer, doctor. You can have symptoms of pressure on the optical apparatus, nerve chiasm tracts, or pituitary itself, and you may get headache, visual symptoms, pituitary dysfunction, or you may get hypothalamic dysfunction. And in the pituitary, you may get anything, but usually it is hypopituitarism.
All of them.
No, I said most of the cases they are hypo. Yeah. So hypothyroid, hypocortisemia, hypo-LH, hypotestosteronism, so amenorrhea, sexual dysfunction, etc. But you may get hyperprolactinemia because you push the stroke.
So my question is, do you get all of them at the sudden? For example, we used to have hyperprolactinemia, that tumor, large tumor in the cyclic diagram. We used, for example, then. But this one, is it, do we lose all of them at sudden, or begin moderation hypocortisolism?
Yeah, of course. It's usually gradual unless it bleeds or something happens to cause it to increase lesions suddenly. So these are the disturbances: diabetes insipidus, hyponatremia, and even precocious puberty. There are few cases of precocious puberty, females having the age of menarche at 6 or 7, or a male boy with genitalia of an adult. So precocious puberty is one manifestation of the hypothalamus affected. So this is a real disease. It's not just a cyst. In fact, some people consider it as tumor. So what's the treatment? Simple. If they are asymptomatic, do nothing. Just wait. Wait and just repeat MRIs. If they are symptomatic, you go for surgery. And this is one case where it was stated conservative, reported in literature, presentation and outcomes in surgically and conservatively managed patients. This is John Jane Jr. from Virginia. And this is the case before, and this is on follow-up. It just shrank without any treatment. So if you want to treat, how would you treat? By surgery, by chemotherapy, by radiotherapy. How come? These are not tumors, so why are we doing chemotherapy? And why are we giving radiotherapy? I'll come to that. Surgery is via either transnasal, whether endoscopic or microscopic, and via craniotomy. And the aim is to partially excise or mobilize, and sometimes they put some alcohol in it to kill the cells inside. Now, before the 1990s, or the era of endoscopy, the majority were dealt with by craniotomy. But after 90, because of the surge of the endoscopic, the majority are done by endoscopy, endonasal. And you just leave the craniotomy for large supracellular, or if it is totally supracellular. So the aim is to drain the cyst and remove as much of the capsule as you can. So this is the craniotomy, picture, optic nerve chiasm, carotid, A1, A2, A1, A2 will come. So you find the cyst, if it is supracellular, it will be here. This is the stalk coming from the hypothalamus to the pituitary gland, carotid, middle cerebral, anterior cerebral. That's the picture of a craniotomy. And people would recommend that you do orbitozygomatic approach for this large cyst. So craniotomy is still needed. And this is the beauty of the endoscopy. We are seeing a new anatomy via the endoscope. Here you can see the pituitary gland, you can see the chiasm, you can see optic nerve. Here is the lamina terminalis. If you go underneath the chiasm, optic nerve, chiasm, you will see the stalk going to the pituitary. So it's a beautiful approach, no doubt about that. And I always maintain that in endoscopy lies the future of neurosurgery. So these are the cases of transsphenoidal approaches. Transsphenoidal endoscopic approach in treatment of Rathke's cleft cyst by Giorgio Frank from Italy. You can see before and after. So this is one of their cases, endoscope through the sphenoid sinus, and they can see the stalk and they can see the cyst. This is the basal membranes. Another paper, again by group Ricardo Caruco from France, these approaches for the endonasal approach. And the usual postoperative complications, of course, diabetes insipidus and trichomonas. And the most important complication in endonasal is, come here tomorrow. This is my daughter, I allow her to come in, even if she's late. Is the CSF leak in the transnasal approach. But this is important one for you, doctor, again. People with pan-hypoaldosteronism do not usually recover. And what happens if they recur? This is a huge problem because they have high rate of recurrence. 3 to 33%, almost 1/3. Let's see, recurrence. In this paper, 12.5%. This is first time after surgery, it's recurred again. Another case, surgery, it's recurred again, and recurred 3 times recurrence. And why do they have recurrence? Because there are risk factors. Maybe the inflammation that the mucin would cause. Maybe it is the squamous metaplasia that they may go through. And usually you see the recurrence in large sizes of cysts, in the presence of a solid lesion inside the cyst, and if you do partial excision. So you have to go for complete excision as much as you can. I mentioned about radiotherapy. It is not tumor, so why should we give radiotherapy? People say that if you are lost, you have done 2 or 3 times of surgery, then you may try it, but it is not established. What about chemotherapy? Bleomycin. It's been used for symptomatic recurrent Rathke. Again, it is palliative approach. It is something that you may like entertain to do if everything fails. And this is one paper from the University of Colorado. This is the cyst. This is, of course, the cyst that had 3 times surgery, and they gave her bleomycin, and it just shrank. Have you seen that, Ella? Bleomycin being used in Rathke's?
Well, I've seen it in other cysts, not necessarily Rathke. It's one thing for it to be used as an injection in the cyst. The question is this superior to injecting using alcohol?
Sure.
And whenever you get those, it's a series of you're injecting a cyst with one method or another, and nobody ever compared bleomycin to alcohol injection to show if there is anything, or if just emptying the contents of the cyst is what you have actually achieved to the maximum degree, and bleomycin actually added nothing to.
I just have a break before we go into our case. You just mentioned Rathke's pouch in general. We'll come to the case of ours. But before that, I'd like to pay tribute to one of the giants of neurosurgery, not in Jordan, but in the Middle East and the world at large, Dr. Salah. Salah was born in Ramallah in Palestine. This is views of Ramallah. Beautiful city. الأغنية تبعتنا وين على رام الله معروف مش. At the age of 16, I think his daughters are here, yes? Correct me please if I'm wrong. At the age of 16, he went to Austria, right? And this is Austria, beautiful Austria. You just dream about visiting because of the music, because of the beauty of everything. Yeah, but for me, Austria means something to me. Sound music.
Very good place to start. When you read, you begin with. When you sing, you begin with do, re, mi. Do, re, mi, do, re, mi. The first three notes just happen to be do, re, mi. Do, re, mi. Do, re, mi, fa, sol, la, ti. Do, a deer, a female deer. Re, a drop of golden sun. Me, a name I call myself. A long, long way to run. So, a needle pulling thread. La, a note to follow. So, tea, a drink with jam and bread. That will bring us back to dough. Oh, oh, oh. A deer, a female deer. Ray, a drop of golden sun. Hey, a name I call myself. A long, long way to run. So, a needle going thread. La, a note to follow. So, tea, I drink with jam and bread. That will bring us back to dough. A deer, a female deer. Ray, a drop of golden sun. Me, a name I call myself. A long way to run. So, a needle pulling thread. La, a note to follow. So, tea, a drink with jam and bread. That will bring us back to dough. The rainy Maserati dough.
Sorry to try that.
Thank you for bringing flooded memories.
Julie Andrews, yes. I saw this film as a kid, and I promised myself I will show it to my kids when I get married. And I got married and I got children tomorrow. And I said, would you stand up, please? And I made them see this film 100 times. Yeah, so they know the songs by heart. Because I feel there's so much messages there. For me, Austria is not only about the beautiful scenery or the classical music of Strauss, Bach, and Beethoven, but it's also about this film. And Austria came to me to denote and point to Salah Salah. So in Vienna, he studied at the University of Vienna under the patronage of Dr. Professor Wolfgang Kuss. Can anybody pick where is Salah? There he is. Long hair, which is not him, but that time he had long hair. And this is the colleagues of his, including some of the friends that I will mention later on. One of his colleagues, trainees, was Engelbert Knosp. He was his mate, he was a resident to them. So he excelled there, and he actually showed that he is the kind of person that will have a great future. And he worked hard. Look at the years, 1969, 70, 73 papers that he produced with his boss, Wolfgang Kuss. Beautiful papers, not only that, but he also shared them writing chapters in books. So Salah was the kind of model of a neurosurgeon's internationally renowned model of a neurosurgeon. He came back to Amman, 79, and I believe that was upon the request of King Hussein himself. At that time, the King Hussein Medical Center was empty of neurosurgery because Dr. Ishaq Marqa has left with the Dr. Ashraf Kurdi, so there was a vacuum there, and His Majesty ordered Salah to come back, and he did, and he stayed in there till 1985. And then he went to his private practice. But before that, in 83, that's Salah, of course, نعرف موريس موجود موريس أشرف كردي وليد معاني عادل الشويدي دكتور أبو الرب محمود الكرمي ساقم ماشي ينادي حسن جدعان. They formed the Jordanian Neuroscience Society. He was a very prominent surgeon, and in my contact with him, that I was resident with Dr. Idmani at University Hospital back in 79, 80, and there were only two surgeons there at that time, Salah Medina and Professor Mani in the university. Nobody else, so they covered the whole kingdom. And if one of them goes into holiday, the other one should cover for him. And many a time, I was to cover with Dr. Salah the whole kingdom. So I learned a lot from him. He was the Speedy Gonzales of all the Speedy Gonzaleses that you know. He was quick and to the point. The surgery may take 10 hours if it needs to be, but if it doesn't, he doesn't mess around. He will do it in 1 or 2 hours. And people used to joke that by the time, if you are a relative of a patient, by the time you smoke a cigarette, the surgery will be finished. That's how practical he was. In the private, he worked in 3 hospitals. Italian Hospital, which is, by the way, was founded in 1927, Khaldi Hospital, and Sbeih Hospital. In fact, his name became synonymous with Khaldi Hospital. So you say Salah, you say Al-Khaldi. And his clinic in the Khaldi Hospital was a Mecca for all patients, poor and rich. This is some of his friends. This is Khalid Shammas. He attended his wedding. This is how humane he was to attend the wedding of his resident. And of course, you know the faces here. Here you are. Just in time. We are halfway. I sent it to you. He received many awards and recognition from everywhere. He was one of the founders of the Jordanian Society, the Pan-Arab Society. But above all, he was a humane man. He was an excellent neurosurgeon. I learned a lot from him as a resident. I'll take you now to something personal. Back in Vienna, 2014, I was elected as member of the World Academy of Neurosurgery. I did not know about the thing at all until I reached there. For me, it was just a conference, but everybody surprised me that they have elected me. This is inside the library of Vienna University. It is 700 years old. 700 years old library. The roof is full of the statues of scientists and etc. And in the floor there, this is the roof. You sit and you argue and you fight and do things the way you like. So this is the World Academy of Neurosurgery back in Vienna 2014. This is myself, and I found myself standing with the giants of the world. I don't need to mention names, but these are giants of the neurosurgery in the world. All in all, the members of the World Academy are 72 members of the whole world. So it is a privilege. But not me alone. We were 4 there. 4 Arabs were there. Myself, Dr. Ahmad Kanaan, who is also Jordanian, and Dr. Sam al-Mufti. So Sam al-Mufti from Syria, Ahmad Kanaan and I are from Jordan. Who's the 4th? Salah. He was there with the soul, with the ways people treated us like Jordanians. Oh, yes, you are coming from Jordan where Salah comes. So we had got the respect and recognition just because Salah was there. And this is me presenting my cases in that room. And as I said, it is heated discussion. Why should 70 people sit there alone and discuss? Because we want to take it into a very high level. This is very precise kind of discussion that you don't do in the usual conferences. So people like Spitzler, Robert Spitzler, and people like Engelbert Knosp. Knosp, as I said, was his friend in residency. This is myself with his wife and his daughter. And this is Robert Spitzler meeting with the king in a delegation that came to Jordan, and him in my house. So it's a privilege to be there with these people. And this is my message here, that Professor Spitzler and again Engelbert Knosp spoke about Professor Koos, who was the mentor of Salah. And both of them mentioned the name of Salah. Salah was here, Salah did that, Part of the history of this man who trained many people around the world. Salah died at the age of 68, I think back in 2012. It was a sad day for me, and I wrote this piece about him. I hope you can read it later on. Can we stand a minute of silence or read الفاتحة على روح الدكتور صلاح؟ Thank you. And just a couple of days ago, we lost another giant, Dr. Mahmoud Fayyad, who was the chairman of the radiology department at King Hussein Medical Center. I will talk about him next time, to give him his due of respect and remembrance. Mahmoud Fayyad was there at Medina, King Hussein Medical Center in 1978 when the first CT scan in the Middle East was there. We were country number 7 to have the CT scan, much earlier than most of Europe. So this man has a great history. I will mention it next time. Back to our case. Our case for today is 35-year-old female Jordanian, and this is back 2014. She complained of blurry vision of 3 months, left more than right. She complained of morning headaches. She complained of nausea and general fatigue. She was diagnosed in the past as primary hypothyroidism, or maybe it is secondary, but she was given thyroxine at that time, and her thyroid was related to the cyst that she had. She had recurrent abortions, she had menorrhagia, she had hair loss, she had heat intolerance, the whole spectrum of endocrine disturbance, in addition to the visual disturbance. So it was very symptomatic. But being symptomatic from the visual point of view, and Dr. Ibrahim, I'm sure, will allude to that, doesn't mean that you will find solid findings in the ophthalmology. You may not see anything because just the patient is complaining. So she had 2 cesarean sections. General examination was normal. Vital signs were normal. Neuro examination was okay. Cerebral signs normal. Gait normal. That's the patient. Her eyes movement are okay. Facial is okay. I will come to that with Dr. Ibrahim later on. No weakness in her upper or lower limbs. And her biochemistry and hematology were okay. Elevated little bit of prolactin. I'm not saying that she has, but at the time when she came to us, she was given anti-prolactin treatment. And most of the gynecologists, once they sense there is a high prolactin, they will give the treatment, which is wrong, because you have to know what's the cause of it. Let's see the preoperative images. This is T1 before contrast, this is T1 after contrast. You can see this is stroke, and this is the pituitary. And in front of this is the supracellular, totally supracellular Rathke's cyst. These are the pictures. So before and after contrast. This is the cyst. Again, in the coronal view, it's totally above. There it is. This is the angiogram, which we always do, MRA, MRV for every patient. Let's see how difficult the differential diagnosis is. Despite all the advances in the neuroimaging, not Euroimaging, neuroimaging, it is still a problem to differentiate Rathke from craniopharyngioma from pituitary lesion. Why should we bother? There is a lesion, we'll just go and operate upon it. Or, in this case, if there is hyperprolactinemia, somebody may give the medical treatment and send the patient home, which is totally wrong. That's why differential diagnosis is not a mental exercise, it is a practical exercise. It is exercise that you have to practice with every case. What is the lesion? What am I going to do with it? So let's see pituitary lesions that look like Rathke's. You may get hyperplasia. Remember that we said in T1 it could be hyperintense, hypointense, isointense. So is this Rathke or a pituitary? And if it is pituitary, what? Hyperplasia, which you see in pregnancy and lactation like this. Seen Muhammad Juma and Arnaut earlier. Do you see much of these cases?
Yeah.
Muhammad Arnaut, you do. Muhammad Juma,
Yeah.
you do. So hyperplasia is recognized. Not a tumor, it's just hyperplasia during this pregnancy and lactation.
Sorry, Dr. Ibrahim, hyperplasia is common in patients with long-standing primary hypothyroidism.
Sure.
Not treated.
Yes.
It is the concave like looks like pituitary tumor, but
It isn't. Yes. It could be pituitary adenoma. But look at this. Oh, was this Rathke or pituitary adenoma? It's one patient of mine, and it was pituitary adenoma. Another case is actually of pituitary adenoma. Again, look at this. Very much look like Rathke. You may get apoplexy in adenoma like this, and you will wonder, is this Rathke cyst? There's a fluid level. Still, you may get fluid level in apoplexy or Rathke. Apoplexy in one of my patients, pituitary apoplexy, as the histology confirmed. Or there could be apoplexy in large adenomas. Again, we mentioned that Rathke could have some solid component in it. Pituitary apoplexy in one of my patients. Lymphocytic hypophysitis. Again, it looks like Rathke's. Again, question for both of you and the endocrinologist. Do you see lymphocytic hypophysitis?
rarely.
Rarely. How much?
It is rare.
It is, but it is an autoimmune disease like Hashimoto and others. You may get abscess. I mean, who on earth can tell that this is an abscess or Rathke or what? But this turned out to be pituitary abscess. Abscess inside the pituitary. You may get metastasis inside the pituitary. So just widen your vision and widen your knowledge. Empty cella. I always maintain that empty cella is a radiological feature. It is not actual disease, though it may be associated with some pituitary problems, and you should investigate. Even in the empty cella, investigate the pituitary. But look at this. Is this a cyst or empty cella? And empty cella occur because there is an opening around the stalk where CSF can go into the cella, or it could be post-operative, or it could be post-radiation. So it's a complex. But these are the cases of empty cella that I have. Look at this here. Again.
Empty cell, although it is radiological, it can cause severe pituitary distress.
Absolutely.
It can cause hyperprolactinemia. It can cause hypogonadism.
Absolutely.
Hypogonadotrophic hypogonadism. It can cause hypothyroidism.
I can't agree more. That's what I mentioned. That although it is
common.
Yeah, although it is a radiological feature, but it can present with a pituitary dysfunction. Craniomeningioma, as you said, they belong to the same family, so they look the same. And this is one case of mine. Oh, this is pituitary apoplexy. Oh, is this apoplexy inside the Rathke? Turns out to be craniomeningioma. This is the histology. It's confirmed. They presented the septal palsy, which recovered after surgery. Arachnoid cyst. Look the same. Meningioma, small meningioma. Oh, is this a Rathke or what? Again, this is confirmed to be meningioma. And sometimes you have both. You have the pituitary and the meningioma together. So there is an association. Pituitary adenoma associated with meningiomas, pituitary adenoma associated with aneurysms. Epidermoid, one case of mine. I went in, I thought this is Rathke, and it turned out to be epidermoid. Teratoma. So you look like supracellular Rathkes. Langerhans cell histocytosis, disease that we don't think about. It loves the cellular area, it loves the hypothalamus and the stalk. Lymphoma, which is just mentioned then, so that people just keep remembering that lymphoma is only differential diagnosis. So, please.
This would be quick. What would an oncologist be doing in a Rathke discussion? It's exactly this. These are less of true differential diagnosis. These are actual cases. And we cannot stress this more, despite the fact that you're going in almost certain that this would be a Rathke pouch. A Rathke cyst. This is exactly what you would expect. I can't emphasize more the fact that metastases can happen in the pituitary. They can masquerade in a manner like this, and you can easily avoid this by examining the patient well. Even when that you can miss metastases. And LCH, Langerhans cell histocytosis, is a disease entity that is radically treated differently. Abscesses, by definition, are treated differently. Lymphoma happening in this area, which would make it primary cell lymphoma, has serious implications because these patients only need tissue diagnosis. The treatments are going to be radically different. This would be primary cell lymphoma that would be treated mainly medically with high-dose methotrexate alternating aggressively every 2 weeks with an attempt to delay radiotherapy. And they will not need the aggressive or the invasion that would have been entitled anyhow if you have the tissue diagnosis. Albeit this is rare. The reason why I'm stressing this point is that in meetings, multiple meetings before pre-operatively, oh, why would you bother? This really looks like that. Why on earth would you need to insist upon tissue diagnosis? Because if you have this, the patient's implications for treatment are going to be radically different. Another thing to emphasize is this gravitation towards radiating a lesion just because of its appearance, and if it's a pituitary lesion that is failing, or gamma knife, etc. And you can miss something like this, metastasis or lymphoma, with really fatal consequences. We keep hammering this point again and again, and these mistakes keep occurring again and again. If you don't look for something, if you don't think about it, you simply won't find it. And it will be buried as evidence. The evidence will be buried with the patient, the late patient.
Please.
I would like to comment 3 comments. First, differential diagnosis, we will add aneurysm, hamartoma tuberculum cinereum, and hypothalamic glioma. This is one of the differential which we include. For us as a radiologist, usually diffusion will help us in showing 3 things, showing abscess, dermoid, and metastasis. It can help us to show them. What are the typical radiological findings on the Rathke cyst? 3 things. Claw sign, which is Dr. Sbeih has said about it, that the cyst will be surrounded by enhancing pituitary gland. Second, the nodule. The nodule, it appears as hypo in T2, hyper in T1, and it is said that if you see it, you have to think this is Rathke cyst. We see it on the images with Dr. Sbeih of an osborn. There was an arrow posterior on that image. The third one, it is uncommon, rarely seen, but they are saying it is pathognomonic. The posterior lid sign. When the cysts are enlarged, it will push the posterior fossa and it will put it between the diaphragm cilia and the infundibulum. You see as in T2 sagittal images, a hyperdense tissue. This is called the posterior sign and it is pathognomonic for the Rathke cyst, but it is uncommon to be seen. Thank you.
Thank you, Dr. Azman Hariri, Chairman of the Radiology Department at the University Hospital. We'll just proceed now. So, chest X-ray and skull X-ray ECG were normal. And did a few consultation. At that time, the endocrinologist responsible for the case was Dr. Nidal Khatib. Is Nidal around? No, he's not. Maybe one of you, Dr. Jama or Dr. Maut, to comment if you need to comment. Do you think this is a primary hypothyroidism or related to the cyst? And how would you know?
Yes.
Please.
First of all, by palpation, you have to do physical exam. If there is any small goiter, I'll do thyroid ultrasound, I'll do antithyroid antibodies. And sometimes TSH is give you a hint. If TSH, as example, before treatment, I mean, if TSH it is around 3-4 and low T4, most likely you have both. You have mixed primary and secondary at the same time. But if you have, as example, antibodies positive and there is goiter and by ultrasound, you have Hashimoto, most likely you have autoimmune disease from you.
Thank you. Arnaud, you want to add anything? Thank you. To Ibrahim Sadat as an ophthalmologist.
Thank you, Dr. Sbeih. Thank you for teaching us music besides medicine. So basically, this patient was totally normal in spite of giving a history of decreased visual acuity or decreased vision. And why is that? Sometimes we have intermittent phenomena because sometimes the patient does not see well, and at the time of the exam he's perfectly well. Other times we are unable to measure everything. We measure whatever we can do in the clinic. For example, we measure the visual field by the automated perimeter. And the best way to measure it is the 24-2, which measures the central beside some of the periphery. But the far periphery is not measurable by this tool. We can do it manually, and nobody will do it now.
I just want to reiterate what you always say, that you need to lose lots of your vision before you discover that you have.
Right. Actually, our tools are not sensitive enough to detect early vision loss. So whatever we have, for example, I'll tell you one scenario. If the patient was 1.25, and a lot of us have more than one vision, it is 1.1 or 1.2, and he is 1 or 6.6, they will mention blurred vision. And when we measure them, if we don't have records, it is normal for us, but it is not normal. So basically, we first document and then try to make theories. But this patient was totally normal for us. So if we want to elaborate, this is one way of measuring the visual field. It is done in another hospital.
Yes.
It was okay, actually.
The anesthetist at that time was Dr. Nasser Jabir, and he declared the patient to be fit as American Society grade 1. What does that mean, Dr. Mawia? Grade 1. So no problems, no complications. Perfect.
Thank you. Actually, I mentioned last time about American Society of Anesthesiology. They say 1 to 5, and we said the ASA1, which means perfectly normal life, and there is no disease which affected his daily activity whatsoever. Whereas ASA2, any disease, he is diseased, but it does not affect his daily activity at all. Whereas ASA1 has no disease. ASA3, he has a disease, and it does interfere with his daily activity. ASA4, he's diseased and moribund. 5, probably he's 24 expected 24 hours. And I mentioned as well, there is an emergency. Just I want to mention to this case about it's just not anesthesia. We've seen several cases in particular, and as you mentioned, usually it's pan-hypo, most of things, and hyponatremia, hypopituitary, have this type. Sometimes they have this insipidus And we've seen some cases diabetes that did happen on table in surgery. So these things are challenges for us in anesthesia rather than, because usually are, as you mentioned, pediatrics or adults. So they are fit and ASA1, very rarely ASA2, but unfortunately they're good disease. And when they are hypothyroid, and remember as well one case we couldn't, long time ago, we couldn't recover the patient at all. Then we have to crush thyroxine, put through the nasogastric tube to speed up recovery. And then hyponatremia is a problem. And when the diabetes insipidus happens sometimes on table, we see it on table, it did happen several times. So the challenge is really with the metabolic derangement that does happen. And sometimes it does happen sooner than you think. So they should be followed up really closely and followed up quite close.
Wow, I want to ask, what is the relationship between any disease that affecting daily life activity? Suppose patients with osteoarthritis and he can't move. What is the risk for surgery in such cases? I don't find any connection between these two.
I mentioned last time, this classification has been invented in the 1970s. Now we are almost 2020, so we're talking about 50 years later. We couldn't manage to come with any better score because we are trying to unify a group of people, a group of patients coming for all kinds of surgeries, from minor hernia to the cabbage or brain surgery. And you need a score to classify it to be simplified and give you a hint to go further. So this ASA1, it does not give you clearance, or it gives you a hint. This patient is ASA2, which means he's got a disease and it does interfere with his daily activity, i.e., as you mentioned, he's got peripheral vascular disease, claudication, rheumatology, or whatever. So check his heart, or it does give you a hint to go further, but no way this classification, it's a clear certificate to go. So it's for us to give us something to go look for.
And it's just risk stratification.
It is a risk stratification. Absolutely. It's very similar to glaucoma scale. It's so old, but it's still valid.
مريض ما بيمشي. مريض ما بيمشي، انت حكيت ايش بيأثر على عمليته؟
لا هو حكى عنده arthritis.
عنده severe osteoarthritis.
Exactly. والموفمنتاته قليله، وظيفات عاليه، high risk for مثلا MI during surgery, blood pooling, venous stasis يعني.
Severe osteoarthritis, it has nothing to do with surgery.
Itself, yes.
This is not unique to ASA. I mean, a lot of risk classification scores, like the ECOG performance score in oncology.
Absolutely.
If I break my leg, I'm bedridden. If I have a pelvic fracture, I'm bedridden. This is performance status score, which is numerically equals to the worst cancer patients there is from just because I'm bedridden. The fact I'm bedridden makes me at a higher risk. It's a very rough thing. Most patients who are bedridden because of their disease. Just when you're putting performance scores in order to make sense of data, you have to put cutoffs. Otherwise, you never get anywhere.
Exactly. I mean, we are talking here about exceptions. You are talking about broken leg. He's talking about severe osteoarthritis. We're talking about, these are ASA classification. As I said, they are trying to find a group of patients coming for all sorts of surgery, from circumcision to brain surgery, from a surgery who is going to last 5 minutes to 15 hours, from 1 year old to 100 years old. So you can't go that deep. Otherwise, you need whole. But this, as I said, it gives you something then to go and look after. But this is, as I said, 50 years later, is still valid. It's still the best classification ever given.
الأس1 والأس5 بيختلفوا الأدوية اللي بتاخذوها في التخدير ولا أنتوا يعني؟
لا الأدوية هي سيم أدوية. بس لا بس طبعا في دوزز وفي هذا بعدين تعال تفضل اعمل فيرست ايد ان
شاء الله. لا بس
لا هذا موضوع صعب كثير.
دكتور عباس الطويل، دكتورة سحر حدادين، انستيست في مستشفى الجاردين. Do you have any comment؟ تفضل. دكتور عبد الكريم عبادي.
ASA classification is important also for mortality and morbidity. The ASA 1 mortality and morbidity is this far from ASA 5. You might reach more than 50-60% mortality and even more. But this is important also for mortality morbidity, less for disease only.
Sure. But Sahar, you have anything to add, please?
I would say like the ASA classification, it's more like for the systemic diseases. I would look at it more like systemic disease, cardiovascular disease, endocrinology disease, respiratory diseases. It goes under more to give the risk factors.
Thank you very much. So we've got the consent for the surgery, and I wrote in the consent craniotomy for excision of pituitary locus lesion. I don't know what the lesion is, adenoma or whatever. Mentioning the complications in details. As I said, the consent should be tailored to the patient condition, not the usual general consent of hospitals. So the lesion in this case, I know it is sitting here. So I would not go through transnasal route. Some people with endoscopy may go like this, but I prefer the craniotomy. And you have to remember the anatomy, the nerves, the chiasm, the arteries there, the ophthalmic artery, etc. And this is the look when you use the pterional approach. The chiasm looks like this. This is from the surgery itself, nerve, chiasm. So you can go this way between the two optic nerves or between the optic and the carotid. So let's see the surgery. We're about to finish. It's not going to take time. So it's a pterional approach. Now we're reaching to the optic nerve. We'll just move fast. This is the arachnoid between the two optic nerves. You use the sharp dissection, sharp scissors, and then you're starting to see the cyst. Exactly where you expected it to be, between the nerves sitting on the chiasm. Here, cutting the arachnoid on top of the carotid, so that I would open this window, optico-carotid window, or inter-optic window. And then once you see the cyst, you puncture it with the bipolar, use the knife, you get the content out, it's mucinous, milky, and then after that, after debulking or the suction of the cyst, then you take the capsule. And you take it from here, you take it from there. And just go through that quickly. That's still the cyst. This is the capsule itself being separated from the optic apparatus. I thought you are only addicted to lymphoma, you are also addicted to coffee. Allah. So this is the capsule being removed to the last piece of it. Now I'm going between the carotid and between the optic and the carotid, make sure that I see the stalk being preserved. So, you go this way and you go this way. Pterional approach. Of course, sometimes you have to open the sylvian fissure between the frontal lobe and the terminal lobe. And how to open the sylvian fissure is a lecture on its own. This is hemostasis and closure. Okay. Good. You want out? So the pathology, Dr. Hassan Farsakh.
I would like to thank Dr. Ibrahim for remembering Dr. Salah Samar. I am a pathologist. I don't meet people a lot. I talk to them over the phone. I probably saw Dr. Salah one time or 2 times, but I talked to him over the phone probably over 100 times because he has a unique character. I don't think many people knows about it, that he does not He is very sincere with his patients. He doesn't want to operate when it is not necessary. So he was asking me all his time when he was there to do CT guided biopsies on vertebral body masses and vertebral paravertebral masses. We have diagnosed many cases of TB and lymphomas and metastatic carcinoma. We saved the patient from high expensive bad surgery because he really does not want to cost the patient more than it deserves. And this is a character that's not present in many surgeons, because many surgeons, they like to operate thinking of the patient as a money bank. But I think Dr. Salah, he really looks as the best care for the patients. I did so many cases with vertebral body mass at Los Milla Hospital with Dr. Joseph Hamam. We were a couple that doing most of the cases of Dr. Salah. So this is very good character that we really need to have our surgeons habit to really save the patients and think him as a whole, not as a money bank. This is back to the case. This is a case is Radke's clip cyst. Radke's clip cyst is a simple cyst. You can see it's usually ciliated columnar or cuboidal epithelium, and there are stromal cells. You can see some mucin probably in here that we could see the colloid material in there. And we can see the cilia is very prominent. And you can see here, this is the pituitary gland that's compressed. And we'll show you how we know that it's pituitary glands and why these patients may have hypopituitarism. Again, you can see the cyst. This is the pseudostratified epithelium, and this is the cilia. And this is these glands are pituitary from the pituitary compressed tissue. Again, you can see it's very simple layer, very thin basement membrane, and these are pituitary, normal pituitary that's compressed residual pituitary taken by the surgery. You can see mucoid or mucinous material inside them. Some of them they have cholesterol or febrile background and some calcification. And again, this is the lining, simple lining, and this is the pituitary glands, and with hemorrhage in some areas. But this is the pituitary glands, normal pituitary tissue. We did immune staining in this case. Cytokeratin 5/6 was positive in the tumor cells or the lining. And this is cytokeratin 7 that also was positive in the lining epithelium in the Radke's cyst. Cytokeratin 19, I want just to mention 1 minute. I mentioned many times that cytokeratin 19 is present in all the cysts that we see in the brain. And I think I need somebody to, as a resident for somebody, to write this up, because nobody mentioned that cytokeratin 19 present in cysts of the brain. We see them in the Radke's cyst, in craniopharyngiomas, in epidermoid cysts, dermoid tumors that are present in the brain. In contrary, when they are not in the brain, cytokeratin 19 is present because probably they originate from the floor of the mouth. And this is very important observation. And I would like to cooperate with anybody who likes to write this paper, because I think it's important to put it in the literature to use cytokeratin 19 in cysts of the brain. High molecular weight was positive in these cases. Catenin B is positive. It can have cytoplasmic or nuclear staining. It usually nuclear staining present in craniopharyngoma, but cytoplasmic, the nuclei are negative, is present in other cysts of the brain. Chromogranin is the marker that we knew that this is pituitary. See, it's positive in all these. The brown stain is the residual pituitary that's compressed by Radke's cyst. K67 usually is very low. This case was less than 1%. So this is Radke's cyst. One thing that I just to remember to mention that Radke's cyst present many times in the usual in the incidental findings of pituitary adenomas. Many times Dr. Ibrahim sent pituitary adenoma to me, and I found a small or minute Radke's cyst. And he mentioned that Dr. Ibrahim that about 35%, up to 35% of normal people at autopsy, they may have Radke's cyst. So it's not something abnormal But when it's large and causing symptoms, probably this is what causes it abnormal.
It is the commonest incidental finding in scenario. Okay. Post-operative course, she recovered well on table. No one is allowed to be moved from theater unless they are awake. They are not, so we have to know why. MRI is done the very following morning, no delays whatsoever for any reason. No, they must have MRI. If they have MRI before, they must have MRI after. Don't kid me by doing MRI before and then CT scan after. You are trying to hide something. And this is the immediate post-operative MRI. Total excision. And this is comparison. Pre, that's the cyst. Post, there's no cyst. She was observed, of course, for diabetes insipidus, the usual post-operative. You have to observe carefully the sodium and Dr. Arnaout and Dr. Juma, they have been in with me in these cases. They actually are part of a major part of the team that I don't just operate and just throw away. They can go into major endocrinological and electrolyte imbalance. And the credit goes to our colleagues here. So this is routine follow-up of her sodium and potassium all the time, and the urine analysis. She made good recovery, discharged in the 4th post-operative day. Here she is. And that is the discharge summary. Again, discharge summary is not the flimsy paper that residents write. Admitted so-and-so, discharge so-and-so, CT scan was done, creatinine was done, discharge. It is flimsy, pathetic kind of discharge summary.
Writing forgot in the usual manner.
In the usual manner. Yeah, creatinine was done in the usual manner, yes. That was what. So everything that has been done to the patient should be mentioned, the surgery in details, the pre and post-operative pictures and the analysis and the medications on discharge, and the follow-up appointment. 4th of January at 12:30 p.m. It has to be specific. مش راجعنا في العيادة. Come to the clinic. No, it's nonsense. There's no respect for the humanity of the patient this way. So 1 year follow-up, no recurrence. 4 years follow-up, and we mentioned that these are naughty for their recurrence. So this is 4 years, and there is no recurrence. And that's the patient and her last visit, and doing very well. Before we go, Dr. Samad is here.
Yes.
Please. You want to make an announcement? Yes?
Good evening to all. Next week, our lecture will be the most anticipated brain death lecture, وطبعا ثقافة الضرب والإرضاع. راح تكون بالفيرمونت هوتيل 6:30 next Wednesday. So most welcome and pleasure to all. Thank you. برضو ممكن بس بنات المرحوم دكتور صلاح you can make your way also here. حابين يشكروا كمان دكتور إبراهيم.
Dr. Salah had 7 daughters, I believe, yes?
Yes. Today we managed to bring 4 out of 7. Achievement. شكرا لك جزاك الله كل خير دكتور.
And I would love you to meet my daughters.
أنا دكتور إبراهيم.
خليكم مع سوا بدنا نسويكم مع دكتور إبراهيم.
غنيم أخي العنقود هي. تتصور جنب دكتور
Dr. Salah Khan, a very special person, a very nice friend, and a human being, different than many other people. I had so many of my professors that had 3 girls, 4 girls, and they were cursing every day. They wanted the boy. They started checking if they can one more, they'll have 5, and they would curse more. But the only one that was so happy to have 7 was my friend, Rahimahullah Salah. And look at them. We are all proud of you all. Thank you for coming.
You were the pediatrician as well?
Yes. هذا حبيبنا للكل يعني.
You were the pediatrician of everybody in the country?